Welcome to the Central Venous Catheter Skills demonstration, or CVC. This demonstration will cover 3 skills: the CVC injection cap change, the CVC dressing change, and the CVC removal. If assigned for checkoff, you will need to perform 2 of the 3 skills, either a CVC cap change and a dressing change, or a CVC cap change and an entire CVC removal. To be successful in this skill, you have to be familiar with the equipment that you will be using. There's 2 different types of chest mannequins. One of them has this blood reservoir in the back, and this mannequin is appropriate to be used for the CVC cap change and the dressing change. The other one does not have a blood reservoir. This one is appropriate to use for the removal. You're also going to need to know which ones require a physician order and which one does not. The cap change and the dressing change do not require a physician order, although you do have to follow your hospital's policies and procedures to know how often and when to change them. The removal you will need a physician order for, so you will be verifying that in your introduction with your patient. Let's begin. Now you're ready to gather your supplies for the CVC cap change. You will need an intermittent injection cap, a 10 ml lower lock syringe with 3 ml of normal saline, a pair of disposable gloves, tape, which you have to add to your skills list, supplies list, and a mask. Now, what I recommend is this mask is in your CVC kit. In practice, you go ahead and open your CVC kit, take it out. You can use it for practice, but you also need to bring it with you for checkoff. So make sure that you have this for checkoff. Something to consider also, for your skills supplies, it reads that you need to bring heparin and alcohol swabs. You don't need this for this skills checkoff. So you can go ahead and scratch those off. Now that we've gathered our supplies, it is time to prepare our equipment to do our CVC cap change. First thing that we're going to do is make sure that we haven't gone into the patient's room. This can be done outside of the patient's room or in a medication room. We're going to wash our hands, and then we're going to prime our injection cap with our normal saline. So let's go ahead and do that. We're going to open up our injection cap port, attach our normal saline, and make sure that we prime our cap with just enough normal saline to get a little bit of fluid in there and push out all the air. Step 3 in your skills packet includes heparin. Evidence-based practice has shown that you don't need to heparinize the central venous catheter line. Regular cap change and flushing with normal saline per your hospital's policies and procedures is enough to keep it patent and keep it working just fine. So you can go ahead and scratch that off.
Coming in.
Hello, I'm Nurse Midoff. How are you today?
I'm doing great, thank you.
May I have your name and your date of birth, please?
Sure, my name is Brenda Jones, and I was born on May the 5th of 1955.
Okay, thank you, Miss Jones. Do you have any allergies?
No.
Okay, I'm gonna go ahead and just clean off your table, make sure that it's clean. How are you feeling today?
I'm doing good.
That's good. Today, I'm going to be changing your caps, removing your dressing, and also removing your entire catheter. There are a few things that I'm going to ask that you do. There are parts of the procedure at certain times that I'm going to ask you to hold your breath, but I'll let you know when. Other times, I'm going to ask that you turn your head at certain times just so that you don't breathe on your catheter site and we minimize the risk of infection. I'm going to also have you lay flat on the bed with the head of the bed down. I'm going to remove your pillow for that. Is that okay?
Sure.
Okay. Do you have any pain?
No, not really.
You have any questions?
No.
Okay, let's get started. So now I'm going to adjust the bed to a good working height because this is a sterile procedure. I'm going to go ahead and put on my mask. Wash my hands. Put on my gloves. And now visually inspect the central venous catheter site. What I'm looking for is to make sure that there's no visible discharge. Make sure that there's no redness, any swelling in the neck, in the face, or the arm. I'm going to make sure that there's no malodor. And then on palpation, I'm going to make sure that there's no subcutaneous crepitus, that it's not boggy, there's no JVD. Make sure that all my clamps are closed on each of my lumens. Make sure that there's nothing coming back as far as blood in the lines. Okay, Ms. Jones, now we are ready to change the cap on your lumen. Please go ahead and make sure that your head is turned to the left. I'm going to go ahead and take the top off, the new cap. I'm going to choose the cap that I'm going to take the cap off. On the count of 3, Mrs. Jones, I'm going to ask that you hold your breath. 1, 2, 3. Mrs. Jones, you can go ahead and resume breathing. I'm going to open up my line. I'm going to aspirate for blood. I got good blood return. And then I'm going to push pause for 2.5 mLs. I don't feel any resistance. It's going in very smoothly. And then for the last 0.5 mLs, I'm going to create some positive pressure by pushing onto the plunger while closing the clasp on the lumen, like so. And then we are done. You're going to make sure that you do this for all 3 caps on your lumen, and make sure that you put the port protector per your hospital's policies and procedures. And you're all done. You're going to dispose of your gloves and your mask. I want to take this opportunity to explain the rationale behind why we get the patient to hold their breath or why we do certain techniques. Why do we ask the patient to have the head of the bed down, and why do we remove the pillow? We do this to prevent an air embolism. Remember, air wants to get into the chest cavity of the patient. If we remove the pillow and we lay the patient flat, that air is going to rise like anything. We want that air embolism to get trapped in that right atrium of the heart, the anterior aspect of the heart. So that's why we lay the patient down flat. Why do we ask the patient to hold their breath? We ask the patient to hold their breath to decrease the possibility of negative pressure increasing. Remember, when negative pressure increases, air wants to go into an area of negative pressure. When we want to take in a deep breath, our diaphragm flattens, our chest muscles rise, causing that negative pressure. So the air wants to go into that negative pressure to fill in the space. So when we ask the patient to hold their breath, we're increasing that positive pressure inside their chest wall, decreasing negative pressure inside. And so the air doesn't want to go into the chest cavity of that patient to occupy the space in that chest. Why do we do the push-pause method when we're changing the cap? We do the push-pause method for 2 reasons. One, if there's a clot in the line, we want to make sure that when we're pushing, if there's any resistance felt, we stop right away. We don't want to push the clot further, causing a thrombus inside the patient's body. The other thing is, remember, think about a water hose at your home. When you turn on the pressure really high, on your water hose, what happens to that tail end of that water hose? If you push it really high, if you turn on the water really high, that end of that pressure causes the end of that water hose to whip in place. Same thing with this lumen. It's inside the chambers of the heart, or sitting right above that right atrium in that superior vena cava. And if you push that pressure really high, it's going to tail whip the end of that catheter, causing damage inside that atrium or inside the lumen, wherever the catheter is sitting. Last thing, why do we cause positive pressure with the last 0.5 mLs of normal saline when we do the cap change? We do this to cause positive pressure so that there's pressure in the line, preventing backflow of blood coming back into the line and causing stasis there, therefore creating a clot. So we don't want clots to form inside the central venous line. Remember, the central venous line is the patient's lifeline. We give medications, we give hydration, we give nutrition. All of these things, we want to make sure that these lines maintain patency. They don't form clots. Clots are very dangerous to patients. So we want to make sure that this is working properly, not getting clots, not getting infected, and we make sure that we're maintaining proper maintenance of the central catheter line. Okay, students, so this video I'm going to show you what supplies you need for your dressing change and your CVC removal. You're going to need a biohazard bag, which we will provide for you. You're going to need to bring some disposable gloves, some tape, which you will also find in your dressing kit, but I have that off to the side this time around. You need a 2x2 sterile gauze. The suture removal kit you're going to need if you're going to do the CVC removal. And we'll talk about how this differs a little bit when you do the CVC removal versus when you do the dressing change. If you're going to do the dressing change, you're going to need the biohazard patch, and you're going to need to open it and put it into your sterile field. You're going to also have your central line dressing change tray. You're going to need this both for the dressing change or the CVC removal. In there, you're going to see that you have sterile gloves, you're going to have iodine, you're going to have alcohol, you're going to have alcohol prep pads, a mask, extra forceps, but you're also going to have that in your suture removal kit, a dressing, a tegaderm dressing or occlusive clear dressing with a label, so you can label when you changed it with your patients with your name, date, and time, tape, extra tape, gauze, and then a towel just to make sure that you have to set up your sterile field, and then a measuring tape or a ruler. So I'm going to open it up just so that you can see what's inside. When you open up your kit, it's going to look like this. You see that you have your mask, then you have your sterile gloves, you have your tape, you have your sterile field, which you'll open up, set it up so that you can put in all your sterile supplies, your forceps, your tegaderm, your iodine, your alcohol, your 4x4, your iodine prep pad, a measuring tape, and then a 2x2 sterile gauze with a little slit, which we're not really going to use, but you can see that it's there. If you feel that the gloves inside the kit won't fit you, you can go ahead and bring your extra sterile gloves that do fit, and then we'll provide for you the hand sanitizer gel. So now I'm going to show you the process of removing the CVC dressing. At this point, the steps would be applicable if you were doing the actual CVC removal or the dressing change. The steps still apply. Remember that before I've gotten to this point, I've already gathered my supplies, I've introduced myself to the patient, verified the patient's ID, date of birth, checked their allergies, especially for iodine and tape. I've explained the procedure to the patient. I've already put my equipment where it needs to be on the bedside table after I've wiped it down, adjusted the bed to a good working height, ensured adequate lighting. My patient is lying flat with the head of the bed down, pillow removed, patient's head is turned. I've already explained the procedure to the patient. I've already washed my hands. I'm going to don my gloves. I have my mask on. I've already inspected and palpated the area for any swelling, tenderness, or signs and symptoms of infection. So now we're ready to proceed to removing the central venous catheter dressing. What I'm going to ask the patient to do is turn their head to the side. I'm going to get an alcohol pad, and I'm going to use it to remove the old dressing. Now remember that the patient's natural skin oils will help remove the dressing. It might already be pulling on the edges or coming off on the edges. These are mannequins, so they don't have the natural oils that help remove the dressing. So we want to be careful to be gentle, especially around the neck area. It's very sensitive. When you're actually doing the skills checkoff and practicing, these are mannequins, so it's not, you're not going to hurt the mannequins at all. It's not even an issue. But if it's in real life, you might need to hold the skin taut and assess your patient's pain level. You want to go ahead and remove the tape right here. And gently removing, going from the outside of the dressing towards the center. Want to ask your patient if they have any discomfort. Stopping if they do. If not, you can just go ahead and proceed. So once I've gone ahead and gotten closer to the center, I'm going to get my 4x4 sterile gauze and open it up, and then I'll show you what I'm going to do with it. I'm going to put it on my patient. I would put it on my bedside table, but for purposes of just this video, I'm going to do it on my patient so you can see it. But I would probably have it on my bedside table. This right here would be sutured down on the patient's skin so it wouldn't readily move. But I'm going to just secure my lumens as such, making sure not to pull on my actual central venous catheter. And I'm going to pull so that I remove the dressing at the same time that I'm trying to remove that bio patch. Making sure not to be gentle and not pulling the patient's skin, especially around the neck. Before I throw it away, I'm going to coca my bio patch for any signs and symptoms of drainage, malodor, anything like that. It looks good. Remember, my patient's lumen would be sutured. I've already opened up my sterile 4x4 gauze. I'm gonna pick it up from the edge, and I'm gonna apply it over the catheter. Now we're ready to move on to opening up our sterile field.